Thank you all for coming to the second of our webinar series in this month on the NHS and your care, part of our Living Well with Prostate Cancer webinar series. Excuse me. My name is, for those of you who haven't met me before, my name is David James. I'm the head of patient projects at Prostate Cancer Research. So Prostate Cancer Research, we are a medical research charity, and we're focused on the prevention, diagnosis and treatment of predominantly advanced prostate cancer and ensuring a better quality of life outcome for our patients. We're very proud to fund 15 really high quality projects right across the UK, and they all really have a shared aim of helping us deliver breakthrough treatments so that we can one day live in a world where people are free from the impact of prostate cancer. Now, we have a whole sort of plethora of different research projects that take, a whole, range of different approaches. Some of our most cutting edge projects include one where our scientists are using IT and machine learning for artificial intelligence to really see if we can divide and conquer prostate cancer. And so what they're doing is that they're looking at sort of really an enormous amount of data and hoping to work out which cancers need to be treated and which can be safely ignored, and then do that for each individual person. So a little plug here, if you're interested in finding out more about this project, please do join us on one of our webinars next month. I'll tell you a little bit more about that later on, but that will be where Professor Danborough and his team will be joining us to talk about the power of AI and machine learning in the fight against prostate cancer. So we also have projects focused on existing treatments as well, including radiotherapy and hormone therapy, where our scientists are working to see how we can reduce their side effects and ultimately ensure better outcomes for people affected by prostate cancer. So I'd like to tell you a little bit more about one of those today. So, as many of you will know much better than I, hormone therapy is one of the main ways we treat prostate cancer. And unfortunately, it will stop working for nearly all patients at some stage. Now, how hormone therapy actually interacts is it interacts with something called the androgen receptor. So the androgen receptor is a protein on prostate cancer cells that drives cancer growth. Now, what hormone therapy does is it works by blocking the androgen receptor from being able to tell the cancer cells to grow. Now, what we know is that the androgen receptor essentially exists in two parts. There's a bit outside the cell, and there's a bit inside the cell, which tells the cancer to grow. So the outside part, that effectively acts like a switch. And when the switch is on, the androgen receptor tells the cancer to grow. Now, what happens is the hormone therapy that interacts with the outside part of the androgen receptor. Now, at some point, the androgen receptor itself actually changes. So that part outside the cell is missing. There's nowhere for the hormone therapy to stick to. And so the bit inside the cell is it's kind of almost like permanently on. And so the androgen receptor is still driving that cancer growth despite the hormone therapy treatment. So these forms of the androgen receptor, when it's changed, are known as androgen receptor variants, or ARVs. And they're found in up to about 80% of advanced prostate cancer patients. So at the moment, the problem is we don't know how these variants, these ARVs, are made, which means we don't know how we can stop this process and keep hormone therapy working for prostate cancer patients for much longer. So what we're doing is we're actually supporting Dr. Luke Gorgon and his team from Newcastle University Centre for Cancer to explore how these ARVs are made in advanced prostate cancer cells. They're also looking to discover which proteins are critical to make ARVs, and then if those proteins could be blocked with drugs, giving us a new and better way to treat advanced prostate cancer. So ultimately, by preventing the formation of drug-resistant ARVs, hormone therapy resistance could be delayed, reversed, or avoided completely. So now what I'd like to do is play you a brief video from his team in Newcastle explaining what they're doing for themselves, because I found that's typically a much better way. But what I thought I'd do is set them up. So here you go.
Hi, I'm Dr. Luke Gorgon. I work in the Newcastle University Centre for Cancer. So the background to the project has been built on a number of years of working on androgen receptor function in advanced disease. The androgen receptor is present in the vast majority of prostate cancer patients, and it's already targeted therapeutically. And normally when patients are administered these drugs, they respond pretty favourably. Within 2 years, the patients on average will relapse and have the tumour regrowing. And what's happened over the past number of years is the development of what we call next generation hormonal therapies, which are more robust than the first generation compounds that are applied, so that patients who have become resistant to the first line therapies are now sensitive to these next generation treatments. But unfortunately, as with the first line treatments, these second generation or next generation treatments are only short-lived, and the whole concept of our project is to try and develop what we would probably classify as third generation compounds, which can really help provide another sort of effective treatment for advanced prostate cancer patients. So I got into cancer research essentially straight out of my degree, which was in biochemistry. I had a number of interviews for PhDs across different biological fields, immunology, yeast, prokaryotic biology, but the one that really struck home to me was the one that was focused on prostate cancer and investigating the role of the androgen receptor in prostate cancer. So that was back in 1998 when I started my PhD. So essentially I've been now involved in this work for over 20 years now. I'd just like to say from myself, but also everybody who's involved in the project, that we really appreciate all of the fundraisers and everybody who supports PCRC, who's basically making this project happen. So thank you very much.
There we go. All right. So thank you for indulging me there. I just thought it'd be nice to actually hear from the scientists themselves. It's, a nice way to understand a bit more about the project as well. So now, beyond our research, obviously we're dedicated to educating, empowering, and supporting our patient, partner, family, and carer communities. And that was the sort of rationale really behind this webinar series, Living Well with Prostate Cancer, which we're delivering in collaboration with our friends, Tackle Prostate Cancer, who are the UK's National Federation of Prostate Cancer Patient Support Groups. So next month in November, we have 4 really great webinars on the future of treatment. On November the 1st and the 8th, so next Monday and the following Monday, we have actually a 2-part webinar on prostate cancer genetics. So if you are interested in learning more about the genetics around prostate cancer, I would strongly advise you to attend both webinars, as this is a 2-part session, and there are a lot of terms and sort of concepts which we'll sort of be exploring in the first webinar, which will really be necessary for sort of understanding and appreciating the second webinar. On the 17th of November, we have a webinar called Demystifying Prostate Cancer Clinical Trials, and this is going to be led by Professor Andrew Hughes, who's the Professor of Experimental Cancer Medicine team at the University of Manchester, and was previously the clinical head of the Manchester Experimental Cancer Medicine Centre, which is one of the largest phase 1 clinical trial units in the UK. And then finally, as I mentioned earlier, we have a webinar on November 23rd, which is on AI and machine learning, and that's being led by Professor Dan Brewer, who is the senior lecturer in medical bioinformatics and genomics at the Norwich Medical School, and his team, Dr. Dan Woodcock and Professor David Wedge, who's the Professor of Cancer Genomics and Data Science at the University of Manchester. So if you're interested in joining any of those, you can find out how to register on our website. The web link is on the screen, but that's www.pcr.org.uk living-well. Now back to today. So I just want to go through very quickly a few housekeeping points before we get started. This Zoom webinar is a little different to just a regular Zoom meeting. So everyone's videos and sort of audio is off, and that's because this will allow us to record these sessions and then share them with people who weren't able to join us today, and also obviously with yourselves if you wish to watch it again in the future. We will be doing questions after the presentation from our speaker today. There is a Q&A box rather than a chat box, so any questions that you have for our speaker, please just drop them in there, and we will do our best to answer all those that we can after her presentation. So now that leads me on nicely to introducing you to our speaker today. We're very grateful to be joined by Anne Somerville, who's a wonderful prostate cancer clinical nurse specialist and also a member of Prostate Cancer Research's Clinical Advisory Board. So Anne, now would be the moment to unmute and turn your video back on, and I will hand over to you.
Okay, hello everybody. Just a slight hitch. When I'm clicking the video, David, it's saying that your host has asked you to start your... Oh, right, okay, I've got it now. Sorry.
No problem at all. All right, and
okay.
Over to you.
Okay. Okay, so today we're talking about prostate cancer follow-up, which is mostly what we as prostate cancer specialist nurses do. And basically, there are different types of follow-up. And as the slide says, one size just does not fit all. Okay, David, next slide, please. Okay, so we wanted to do a quick poll as to who gets what kind of follow-up. How many of you get follow-up face-to-face? How many of you get follow-up by telephone? And is your follow-up with an oncologist or is it with a clinical nurse specialist? David, have we got...
Yeah, so I will now launch the poll, so that will now appear for everyone. So we'll just leave this open for about a minute for you to just answer the questions.
Okay. Yeah, where is your follow-up, obviously? Is it with your GP? Is it in hospital? And whether it's... or whether any of you are doing your supported self-management, which I think some of you saw a very good webinar regarding this.
All right, great. And now I'm going to shut the poll now, and I'll share the results. But we've just got a couple more coming in, so I'll just keep it for a couple more seconds. I heard from nearly everyone. Great, thank you everyone who's filled that in. And I'm now going to share the results with you. So can you see those results?
I can, yeah. So 76% get their follow-up in hospital, only 10% with the GP. And face-to-face is 40% and telephone 48%. Yeah, so about even, Stevens. Okay, that's really interesting. Great. Okay. Right, so shall we go on?
Yep. And the next slide.
Okay, so I was hoping that if any of you don't already know this, but what you would get out of this is how to get the most from your follow-up appointments, choosing the best follow-up that suits you, and understanding what is on offer out there. Okay. Okay, just a little bit of background. Traditionally, prostate cancer follow-up has been, sorry, our pictures up, just blocking that bit, David. I just can't remember what I wrote. I should have had it up on a separate screen. has been within a hospital setting and includes regular visits to either the CNS or the specialists. And patients generally were never discharged from follow-up. So with the growing numbers, obviously, with prostate cancer being the most diagnosed cancer in our country, it's argued that this isn't economical, of course. And with COVID, of course, that changed a lot of things, certainly within our trust, about bringing patients up to hospital and putting them at risk, and whether it was safe. Alternative non-face-to-face approaches, well, lots of you know this already because there is slightly more of you that get telephone follow-up than face-to-face, so you know that. And of course, the supported self-management, which is, you know, now this is the way to go. This is the way to go forward, and lots of us learning how to get this started up in our trusts as well. And the greater involvement in primary care, we are trying at the moment, certainly within our trust, to have a shared care policy with the GPs, and we're looking for maybe not a GP in every single practice, but certainly some GPs with a special interest in prostate cancer in a kind of hub within the primary care setting. And as you can see, evidence is suggesting that alternative approaches do not result in different rates of recurrence, survival, adverse incidents, and so on and so forth. So satisfaction for 5 years of follow-up with diagnostics, but I've referenced that at the end if anybody wants to take a look. But, you know, this is what we need to know. Is this how you feel? You know, I know from our patients that sometimes they prefer to come and see us than to be talking on the telephone. Okay, next, please. Okay, so traditionally, prostate cancer starts with your GP. You go to him maybe with a problem, or you want a PSA check. This is done, and then he's referring into secondary care, and this is where you're diagnosed with a biopsy, MRI, and so on and so forth. Lots of you will be started on hormone treatment, whether you're having radiotherapy or not, and we start that in secondary care in the hospital, and then it's usually carried on with the GP in primary care. And then the follow-up traditionally has always been in the hospital. So you can see that there it kind of starts one way, goes another, starts one way, goes another. Okay, next. Okay, so what is best for you? Hospital, we talk about secondary care. Obviously, the best thing is you see somebody, you see a specialist. If you have complex needs, if this isn't just, you know, post-radiotherapy follow-up, if you're a metastatic patient, then you have more complex needs and you do need to see people. You know, even patients who are on abiraterone and enzalutamide, we would always see them face-to-face, obviously for their, you know, checks and to get another prescription ordered. But now even this is being done by telephone, and you're asked to have a blood pressure machine at home. This, I have to say, is coming from the pandemic situation. Okay, phlebotomy, X-ray, pharmacy, everything is all there in the same place in a hospital setting. Some people feel reassured about coming into hospital. And obviously, we all have access to your electronic patient record system. Now, that's not to say that GPs don't, because within our trust, lots of our GPs within the bigger commissioning groups do have access to the hospital electronic patient record system, or certainly the results. Okay, so against, well, you know, we all know about traveling to hospital and parking and how much that costs and getting tickets and so on and so forth. The risk of catching viruses, obviously the bigger district general hospitals do have COVID wards. It's an issue. Lots of my patients complain that they see different clinicians at every appointment when they're seeing doctors. And this, they feel they're not really getting value for money. They're just, you know, they want to see somebody who knows them, who knows about their prostate cancer. Obviously, long waits, waiting times, sitting around, waiting to be seen. And, you know, the GPs may not have access to your hospital records, so that's another against. Okay, next, please. Okay, GP. Well, for it's accessible. Lots of us live near our GPs. We can walk to our GP surgeries. Lots of you have got good relationships with your GPs or practice nurses. You know them, you see them at every visit. So it's nice. It's got continuing practice going on there. Less waiting, well, supposedly. The GP usually knows the patients and not just about their prostate cancer, but knows everything else. You know, we in hospital are not always privy to what medications you're on. GPs are really, really good at some things. They're excellent at managing blood pressure and diabetes and skin cancers and things like this. So, you know, and of course it's a safer environment. They don't have inpatients. So well, we all know that this is difficult to get an appointment, particularly now, and why are GPs not seeing patients face to face at the moment? So we do know it's an issue. There are only a few GPs that do have a specialist interest in urology cancers. We used to call them gypsies, so a GP with a special interest, but there aren't so many now. If blood tests or referrals or any other investigations need to be done, then you're going to have to be referred up to secondary care, so that can take time. And obviously not all GPs have access to the EPR system. Okay, next, please. I know you've all had this, or lots of you have already had this presentation, and you know what this is about. So, you know, it's about you taking back sort of control about your care. But I have done a lot of work over this, although we haven't started it in our trust yet. But so you have control over your disease. You can go and look at your PSA and blood results and any other results any time of the day. You should have a direct dial phone number into your clinical team. And of course, there's no waiting around for your PSA result. You'll get it just as quickly as we get it. Well, you're going to have reasonable computer skills, and you have to have access to a computer. Sometimes iPhones and iOS devices are not as easy to get into for results and so on than a Windows or a desktop. You really, to be able to get the best out of this type of treatment, you have to have stable disease. I mean, a patient with complex needs and metastatic disease, I don't think this is in conjunction, but I don't think it would work alone. And obviously you cannot see or speak to a clinician unless you needed to. So those are the points against. Okay, next slide, please. So what is best for you? Well, face-to-face is easier if English is not your first language. And it's easier if it's not the clinician's first language too, because, and hard of hearing, I mean, I do have a number of patients who English is not their first language, they can't hear very well, and therefore telephone is not easy. So it's reassuring to see a doctor or a specialist nurse, and if there's something you need them to physically look at, for example, you know, anything, you know, you could have a phimosis, a problem, a genital problem that's related to your prostate cancer or urology problems, and you need somebody to actually examine you, or if, you know, we need to actually physically examine your prostate, then obviously can't do that on the phone. Non-face-to-face, well, no traveling, so that's nice. Should be convenient and works well if everything is stable and you don't have problems. So that's really, I think, the biggest thing. Obviously less waiting, more control, and a safer environment, which we've gone over already. Okay, next slide. Okay, so how do you get the most from your follow-up? Personally, with my patients in follow-up, because I'm seeing them all the time, it's easy for them to be, you know, confident with me and me with them. But if you are going to be seeing a different nurse or doctor at visits, then write down your questions before you come in. Now, I know lots of you do that, and that's a good thing, because you can either read them out with us or hand over the list, or because it's easy to forget, obviously, so get them written down before. Bring someone with you. Now, I know you're all going to say, no, we're not allowed to bring anyone with us with COVID, and Well, I haven't necessarily stuck to that personally, and I still have 2 chairs in my clinic room. And I think if things are confusing or if there is a problem, you need to bring someone with you. I would never turn away somebody, and I think it's unlikely that a clinician would either. It's hard to take everything in, and you know, if somebody will come back and say, well, I told you this, you think, what? You know, you told me so much. How am I supposed to understand absolutely everything you've said at that time? But that does get easier as you go on. If it's a telephone appointment, then put it on speakerphone. You know, put the speaker thing on your phone so that we can all listen. Make notes if you need to. It can be helpful to write things down. The Prostate Cancer UK have got a booklet called Follow-up After Prostate Cancer Treatment, What Happens Next? And they have pages at the back to write these things down. And sometimes it's just good to keep everything together. And I know lots of you do that. And that's the link to that. So that may be worth you taking a look at if you would like. Ask to record your appointment. We can't refuse that. So that's something you can always do if you want to, but you do need to tell whoever's doing your appointment first that you're going to record them. Ask for help. Don't be embarrassed. If anything's bothering you, just let anybody know. Okay, next slide, please. So what should I ask? Well, you need people, whoever's seeing you, to explain your blood test results. So, you know, for example, obviously you know what your PSA is, and that's been a big part of your prostate cancer. But we take a set of bloods that are very important. We always take a testosterone level because some medications, one of the hormone injections, for example, may not be working or was given in the wrong place or for whatever reason, and you would see a rise in testosterone, and that's important, and we would need to change your hormone injection, and that's what we do as a standard. We also take a liver function and a kidney function blood test, not because we're particularly worried about your liver or kidney function, but within the liver function blood tests, there is a test called the alkaline phosphatase, and that blood test, sometimes if the PSA isn't able to detect cancer as well as it should, what we call a non-PSA secreting prostate cancer, then we go by that alkaline phosphatase. It kind of tells us if there's anything going on within the bones, and it's quite important. Certainly for men who are on abiraterone or enzalutamide, liver and kidney function is essential because obviously they can cause problems related to that. The kidney function, I look at the creatinine, which is one of the kidney function tests, because prostate cancer can, if it starts to grow, it can block off and cause the kidneys to sort of go off a bit. So, and that's our first sign. So it is always worth asking someone to explain if you don't know why we're doing all these tests. Urinary symptoms, or what we call LUTS, lower urinary tract symptoms, particularly after radiotherapy, can be horrible and impact your life. And no one ever seems to be able to sort them out for you. We use voiding diaries, and the link for that's here, and we ask you to complete that 3 days before you come to clinic. And we can look and we can see exactly what you're drinking, what your volumes are. Lots of you do have nighttime peeing issues, and it's something called nocturnal polyuria, and I don't know why, but kidneys do tend to go into overdrive at night, but we can see this from a voiding diary, so it might really be worth doing that. Side effects from the hormone treatment. Well, you know, hormone treatment's not easy, but if there's one thing that's particularly bothering you, you need to ask how this can be managed. Obviously, people want to know what are the chances of the cancer coming back, and would there be any specific signs or symptoms if it was coming back. It can, obviously, once you've had a diagnosis of cancer, everything can make you very anxious. How to take care of yourself, how, when you have muscle strength loss and it's difficult to get going, is there anything out there that's going to help you get going? I mean, we do have some links for chronic fatigue and for fitness. So Tottenham Hotspur do run a club for our patients, so it might be worth asking about this. Support groups, we each have support groups in every sort of section, so our trust is quite big. We've got 3 big hospitals and we have a support group in each of those areas. And I know that lots of you men are not into that, and I know that, but some of you are. If that's what you want to do, ask about them. What long-term side effects or late effects based on the cancer treatment? Well, following radiotherapy, you can get late side effects, and they can be very worrying if you suddenly start to bleed or your urinary symptoms suddenly kick off 2 or 3 years after radiotherapy. I know it's hard to believe, but sometimes that's normal. So if you need somebody to tell you that that's normal or to reassure you, you need to ask for that help. What follow-up tests are we going to need and how often are they needed? Lots of you, once your radiotherapy is finished, you'd say, well, shouldn't I get a scan? And it's funny because the PSA as a screening test, as you all know, is not much COP. But once you have a diagnosis of prostate cancer, it becomes a marker, and that's our test. And we would only start doing imaging and more scans or screening if that PSA started to go up. And it's nice to know what's normal for your stage of follow-up, and is this normal? Is there anyone else out there who's got this? Okay, next please. So what should your doctor be asking? Well, I have a very strict way of, obviously I ask how you are. I go through what treatment I've given you, if I'm giving you hormones, what your blood tests are. Then I ask you the same, and we've got this as a standard so that we try not to miss anything. Nocturia, as we call it, how many times you get up at night to pee. Your daytime voiding, could you sit through a movie for 2 hours without needing a pee? Are you urgent? Do you always make it to the loo in time? Urgency is a big thing, and sometimes you're drinking something you don't even know is causing the problem. So do you have any pain associated with peeing? This stinging pain at the tip of the penis is a really, really common complaint, and you immediately think you've got an infection, and it's not. It's one of these late sort of toxicities from radiotherapy, and very, very common. Are you dry? How many pads do you need to wear? Bowels, we go on to, windy, very windy during radiotherapy and just after. Slime or mucus. Rectal bleeding is the most common. And rectal bleeding can come and go over the years. And if it just happens 2 years or so after radiotherapy, then it's likely to freak you out. And it's almost certainly, well, you can't say almost certainly, but it's very common that this is from a radiation proctitis. In our trust, we try not to go investigating any bleeding within the first year. And that's simply because, going up there with cameras and biopsies is likely to make it worse. But, if you have to, you have to, particularly if there's anything worrying, then you have to. But it is a very common effect. Sexual function, as I say to all my men, there is no treatment out there, perhaps, except for active surveillance, maybe, that doesn't impact your sexual function. It's how we can manage it or whether you're prepared to live without it. And side effects, I ask about your hormone therapy. So those are the things that we should be asking you. Okay, next slide, please. Okay, so this is the next poll. So taking it away from the fact that what we got from your first poll, how would you like your follow-up? So in your ideal world, would you like a face-to-face? Are you happy with telephone? Would you prefer a video follow-up, supported self-management? Who do you want your follow-up with? Doctor, nurse, other, GP? And I can't see the bottom one. Do I scroll down? Oh yeah. And where would you like it? Hospital or GP?
Okay, and there are your responses.
Okay. So, I mean, it's kind of as I expected. Lots of you would prefer to see somebody. Mind you, there's more video than telephone. That's interesting as well. Telephone's obviously the least. Oh, after supported self-management. Well, I think maybe your views will change about the supported self-management as the years go on, and certainly doctor, nurse. Oh, not many of you want to see a nurse. Oh, sad. Okay. All right then, that's great. Thank you for that. Okay. What have we got next? Next slide. I think it's just, oh, right, the perfect follow-up. Yeah, okay. So a place that suits you, GP, hospital. We know that you've said hospital is your favorite, and with a GP or a specialist or a nurse. So we know that you would prefer to see a doctor. Time to talk. You don't want to feel rushed. I know some of you feel that you're kind of in and out, and you know, and you need to understand the dialogue and what's said and make it clear. Feeling safe. What's out there to help you with your side effects, or what kind of alternative therapies, diets, exercise advice, anything really. And reassurance and motivation. I think motivation is one of the biggest things that if somebody is not giving you motivation, it's difficult to get going. And obviously, lots of patients like to have their next appointment booked before they leave. They need their blood test forms if you're using forms, any scans planned or otherwise in place. Okay, I think, is that it? Next slide. I think we've almost finished. Okay, that's just some of the references from there. And I think the next slide, yeah, we use the Bladder Health UK voiding diary. So you just need to get a jug, any old plastic jug. You need to be able to tell us how many mils you've passed, what you're drinking, what type of drinks you're drinking, if you have any leaks or accidents, and what you were doing at the time. Okay, I think that's it.
Thank you very much for that, Anne.
Welcome.
I appreciate that. So we've now going to open up to questions. So there've been a couple of comments come in around, I think, some of the follow-up. I think a lot of people think around this kind of a hybrid model, really, and possibly that might have been lost in our ability to conduct a Zoom poll, is that you know, there would be some people who'd be happy to see a doctor for some, and to see face-to-face for some, and you know, other situations might be happy with a telephone call or to see a nurse, etc. And so I apologize if that we weren't able to convey that in the in Zoom's polls, but I appreciate that those of you who have made that comment. I think that's so also just to answer the questions, the references, I'm happy to put them on screen equally. I will send around a copy of this presentation to everyone who's attended, so you don't have to actually just write them down. You'll be able to get hold of that. So you'll get that in the next day or two. You'll get an automated email with it, with all those references. So just in answer to that question. So we have one question come in saying, I've never had a testosterone check. Should I request one? We do testosterone checks for patients having hormone injections. And we do this so that we are sure that the product we're giving is doing what it's supposed to do. And we also check testosterone following completion of hormones and radiotherapy. And we keep checking that until your testosterone has come within normal range. Once it's in normal range, we don't check it anymore. Now, you can say, well, yeah, what can you give me something if my testosterone hasn't recovered? No, we can't. So why are we testing it? Well, because we like to motivate, and we like to say, look, this is great news, your testosterone's recovered. And, you know, and also if you wanted to pursue your sexual function, if you're making testosterone, then we're able to use the PDE5 inhibitor, the drugs, the Viagras and Cialics. If you're not making testosterone, it doesn't matter what we give you, it's not going to work. So that's why we use testosterone. Thank you for that. Question, if PSA was useful to diagnose a gentleman's prostate cancer. Is it likely that it might not be useful or sort of after satisfactory PSA results for 9 years?
It was useful for diagnostics.
Yeah. So, but then 9 years later, is it still going to be as useful if it's, you know, if it's been looking good for many years now?
Well, the trouble with PSA is it's not a screening test. So we don't have a screening program in the UK for prostate cancer. Why? Because we haven't found one, and we've tried all sorts of things, but we just haven't found one. The PSA is a prostate specific test. So it goes up and down with all sorts of different things going on. You know, you could have a water infection, a prostatitis, ejaculation before you have a PSA test will make it go sky high. Somebody examining your prostate and then you have a PSA test, PSA sky high. You spent all day on a bicycle on your perineum, PSA sky high. So that's why it's not particularly useful to diagnose cancer on its own. But once you have cancer, it becomes a marker. Now, if you're post-radiotherapy and hormone therapy, we discharge 5 years after completion of hormone therapy. So once you've had a diagnosis of prostate cancer and you're 9 years down the line, you've been discharged, it is still useful for you, not as a screening test, but as a marker. So if your PSA starts to rise and you're 9 years down the line, that needs to be investigated for a possible, it's hard to say recurrence because they say after 5 years you're cured, but yeah, a possible recurrence of prostate cancer. So it is useful, yes.
Thank you for that. A follow-up on the testosterone question. A gentleman just asking if you could clarify, so is testosterone level testing important for checking the effectiveness of the hormone therapy or for treatment identification of sexual dysfunction?
When you're on hormone therapy, it's important. And as I've said, we weren't sure whether it was a particular batch of a drug, but we had several, not lots, you could count on one hand, of men's PSAs rising on hormone treatment, and that is not normal. So we immediately switched brand of drugs. So that's why it's now become standard in our trust that we check a testosterone for all men having hormone treatment. After treatment's finished, we check it until normal range to assist with sexual dysfunction.
Thank you. A question, someone is asking the husband's taking Prostat plus Stanti, and if the hormone therapy has become resistant, does he need both drugs?
Okay, so this is a bit more complicated. The man makes the bulk of his testosterone from his testes. He also makes a little bit in his adrenal glands, and so do women. So when the hormone treatment does never stop working. It's just the cancer's very clever and learns to grow again. So we would always continue with hormones no matter what else you have. So then the standard practice is we block the entire androgens by adding in something like bicalutamide in the first instance, which will be, after hormones, I'm not going to say stop working. Once the cancer has learnt to grow again, we call you hormone resistant or refractory. Then we block all the androgens with something like bicalutamide in the first instance, and we call that a maximum androgen blockade. And then if the PSA continues to rise, we call you castrate resistant, because when with maximum androgen blockade, you're completely castrate. Then we add in Zytiga and other novel hormones in the first instance. And if the PSA continues to rise after you've been on Zytiga, yes, the Zytiga is usually stopped, but never the hormone injection, ever. That will continue, always. And if the Zytiga or enzalutamide is stopped, it's usually because you're going to go on to another form of treatment. Is that clear?
Yeah, thank you for that. So there's one gentleman asking sort of a couple of questions in this. If he's had the prostatectomy surgery, does this mean he's cancer-free, or can the cancer come back? And the sort of second part to that is he's saying he still feels very tired and fatigued and sort of really not motivated, or, you know, are there any resources you could point him in the direction of? And I can answer part of that as well.
Cancer-free, is anyone who's had cancer going to be cancer-free? We have different discharging times for radical prostatectomy depending on their final histology grading. So if you were a T2, we would discharge you after a year or even 2. The chances of your prostate cancer coming back with that kind of early disease is very slim. If you had a final histology greater than a T2 and you needed radiotherapy with or without hormones, then yeah, there is always going to be a risk, and that's why we usually keep you monitored for much longer after that. Feeling fatigued, it depends when you had your surgery. Radical prostatectomy, just because you're in hospital for one night and you only have kind of 5 puncture wounds, this is major surgery. This is major surgery that's going to take a good 3 to 6 months to recover from. The trouble is if you don't get going, then it kind of has a counterproductive effect, and then you start to feel even weaker. Now, we do have chronic fatigue clinics within our hospice setting, not for metastatic patients per se, for all prostate cancer patients. And we also have the Fit for You program, which is run by Tottenham Hotspur. So you need to ask your team what's available out there to help with this chronic fatigue and to help get into a kind of exercise program that's gentle enough, low impact enough for you to be able to get some strength and start to feel a bit more like yourself. That's my advice.
Thank you for that. And there's a question come in after radiation, about 3 months later, one gentleman says he's still feeling very fatigued. Is this normal?
Well, it's probably because his testosterone hasn't recovered if he was on hormones. So it can take a year, sometimes longer, for testosterone to recover. And testosterone makes you lose muscle strength and gain body fat. You don't necessarily gain weight, your body shape changes. So you're having to lug around a bit more fat. You probably, because you have lost muscle strength, everything's a bit of an effort, and you probably don't do as much as you need to. And it's like charging a telephone. If you don't get that exercise in, it's a vicious circle. It just gets worse and worse and worse until you lose all muscle strength. But once you start to make testosterone again, it's easier to lose a little bit of abdominal weight. You start to have a bit more strength in your muscles. And that's why we test testosterone, so we can say to you, well, your testosterone's recovered. You do need to get in. I mean, the BBC published a piece of data saying that how many 2 or 3 3-mile brisk walks a week can help with prostate cancer and recovery of prostate cancer. You have to get moving. That's the trouble, to get any kind of benefit from your body. But it's hard after hormones.
There's sorry, and he followed up. He just clarified he wasn't on hormones. It was just after radiation. Yeah. Okay.
Well, that's unfortunate because your testosterone should be normal. So it's exhausting going through radiotherapy because it's having to go up every single day, having to learn to bladder fill and sort your bowels out. It's exhausting, but you need to start building up your strength. So you need to start exercising. Certainly 5,000 steps a day. You've all got phones. You should have it on your phone counter. You need to move your body. So you have got to do that. Even if it's raining, you've got to find a way to get out and to move yourself every day.
Thank you. And then, there have been some questions come in. I think these are possibly more general comments, so I'll sort of make them. They're not necessarily something for you to answer, but I think there's sort of some frustration with coming in from gentlemen saying, they've had appointments, that I work either face-to-face or telephone, and then they're, booked weeks in advance, and then they're cancelled at the last moment, they're not rescheduled. And, sometimes the hospital's 40 minutes away and you can get an appointment, but to park is impossible. But the GP surgery is 5 minutes away, but you can't get an appointment there.
It's a serious issue. I personally run my clinics from the community hospitals where there is free parking, and obviously it's not quite so big and bustling as a big district general, so it's easier to see our patients. But these are patients who need hormone treatment, which we are still giving at the moment. So I understand exactly. And the cancellation of appointments, you're not alone here. I received a phone call this morning, a patient who's on Abiatrone Zytiga, who his appointment is not till next Thursday, and his medication runs out on Tuesday because his appointment had been rescheduled. I mean, it's just left him completely stranded. You need to have your specialist nurse on board there to try and sort that out for you, to make sure, if there is problems here. It's very difficult. Hospitals are terrible to park in. They cost a lot of money. This is why lots of people prefer the telephone follow-up. But it is an issue, and I do understand.
Thank you for that. And there are just two more questions, so unless anything else comes in, we'll make these the last two. One I think is probably sort of connected to your sort of discussion around PSA, but just I thought it might be useful as a sort of clarifier for some. So it's asked, is there a sort of general formula to determine an acceptable PSA level following a prostatectomy, either with or without hormone therapy or radiotherapy? Yep.
Yes, we have a very strict protocol in our trust, and so depending on the final histology of the radical prostatectomy, but basically, if we expect it to be completely undetectable at less than 0.01, if it goes to up to 0.02, then there's a referral criteria, whether you're out with your GP or with the nurse, and we refer you back to oncology. So for a radical prostatectomy, going even as low as 0.02, if we get 2 of those readings, you are referred back to oncology. That's how we manage it. If you had to have post-operative radiotherapy and hormone treatment, the level is a little bit higher. We're looking at 3 consecutive rises or beyond your nadir. So in other words, how high your PSA went at the start of your treatment. But everyone should have those referral guidelines within your trust. So you should know exactly, our patients know if it's up to 0.02, we check it again at 3 months. If we've got another reading of 0.02 or higher, you're off to see oncology. But ours is written down in black and white so that anyone who joins the team, and this was a protocol that was done with our oncology colleagues, so it's exactly as we all follow the same pattern. So ask your team what their referral guidance is following radical prostatectomy and PSA.
Brilliant, thank you. And one gentleman said he's had radiation treatment and he's not on any additional therapy. Is hormone therapy possibly being kept in reserve in case of recurrence?
No. If you have radiotherapy without hormone treatment, or with a short course, 6 months, that means you had a very early prostate cancer, and the radiotherapy, which should have been given over 20 days, then that should have done the job. Hormone therapy would be kept in reserve for prostate cancer that has come back and potentially spread from outside the prostate. So hormone therapy is not curative. It's given with radiotherapy, depending on the stage of prostate cancer you've got.
Thank you. And response came in from gentlemen saying thank you very much for that answer. Okay, so we did get a couple more questions come in. One is from gentleman saying he's going for a radical prostatectomy surgery. What would typically, I know you mentioned that this is a major surgery which can take sort of 3 to 6 months to recover, but he's an avid sportsman and he loves playing hockey. How quickly do you think, would be reasonable for him to start playing again? That's not going to do any, damage.
Sure. Well, as I said, because it just looks like it's minor and you're only in hospital for a night, lots of people would think that this was just a minor operation. Your recovery is done at home. So that's why just because you're in hospital for a night is neither here nor there. Obviously, you go home with a sizable catheter until everything is healed, and then the catheter comes out. And then that's when you could be a little leaky, and that's when you've got to start working on your pelvic floor exercises. So during that time, you wouldn't want to be going out and playing hockey. You use a lot of abdominal muscles. It's vigorous and good for you. But once you're dry and you're happy, then certainly 6 weeks you can't drive your car. Your insurance doesn't cover you. So I certainly would give it a minimum of 2 months if you're a young guy who's as fit as that. And your body's going to tell you when you can go back. You'll know if you're dry and you're using your abdominals, you're not losing any water, you feel fit, you've recovered, there was no, problems or, then because, you have to give yourself blood thinners at home. Recovery is done at home. So don't underestimate it. Be good to yourself, heal and recover, before you start making plans about getting back into something as vigorous as hockey. But good for you. Excellent. Definitely need to get back into that.
Thank you for that. And then, sorry, 2 last questions now. One gentleman has asked, his chemo after 4 sessions has been stopped, and he's being put onto radium-223 as his PSA is raising. Can you explain, what radium-223 is, because he's a bit confused by that?
Okay, so radium-223 is an injection that we give. It's given the same sort of cycles as chemo. It's every 3 or 4 weeks. In the olden days, we gave something called strontium, and it's a radioactive substance that's picked up by the bones. And it can. This is a new form, the radium-223, and it can be very, very effective. I'm really sorry about the chemo stopping, and I know how disillusioning this is, but because you have your bloods checked before every cycle of chemo, if you're not responding to treatment, there is no point putting you through something like that for the last few cycles, because it's hard work, chemo. And so obviously your disease is in the bones, and so radium-223, the radioactive injection, which is picked up by the bones, it can sometimes be really, really effective in getting you back in remission with your prostate cancer that's metastasized to the bones. So that's what that is.
Thank you. And then one question was, are hormone injections painful?
God, depends who gives them, I suppose. Okay, if you're having Zoladex, it's a big needle because the implant is like a bit of matchstick. So it's a big needle. You have to put an implant in to the abdominal outer wall, into the abdominal fat. I'm sorry, I would hate to say to you, no, it doesn't hurt, because any needle you start putting inside somebody is painful. Your flu jab, you feel it for a minute, it's gone. Zoladex, I think, is a bit more painful because it's a bigger needle. Prostate and is also given in the tummy, a smaller needle with a liquid, but it can sometimes be irritating and leave a kind of irritating lump around the belt of your trousers. Very annoying. But if you really totally relax your body, don't tense up your muscles, try to breathe through it, let them do it, and believe me, you'll get so used to this. The other treatment we give is Decapeptyl, and that's an intramuscular injection, and that's given in the backside. And I have to be honest, most of my men complain less about that than they do about the 2 tummy injections. But, an injection is an injection. Sorry, I want to tell you it doesn't hurt. It will hurt for a few seconds and then you'll be fine.
Thank you very much. All right, and I'll make this the final question. So there's one gentleman asking, he had HIFU, partial in his case, and before treatment, his PSA was quite high. It was about 4.4, and it came down to 0.9 post-treatment. Now, that was about 4.5 years ago, and it started climbing, and it's now reached about 3.3 in September. Should he be worried?
I'd need to know what the PSA started at.
1.3. It was around 1.3 after treatment, and then he has had 5 MRIs and a PET scanner, all at clear, including the prostate bed.
Mm-hmm. I mean, I want to tell you that everything is fine. I can't tell you that. If your PSA is rising, then there is probably some active cancer cells there. I mean, you're saying, well, I've had all these MRIs and PET scans. Unfortunately, MRI scanners and PET scans are not microscopes. They can only see what we see. Now, it's very frustrating to see the PSA going up and they've gone searching and they just can't find anything. Whilst the PSA rises, we would all have to believe that there is some active cancer cells within the prostate. And I mean, we don't do HIFU in our trust, and of course there's only the big specialist centers that do it, and particularly because HIFU can just treat one part of the prostate. So it's very appetizing to not have to have the whole prostate treated, less side effects. But I'll be honest, if the PSA is going up, then you would have to think there is something going on and we just can't see it yet. I mean, they could rebiopsy you, but if there's nothing on the MRI scanner to target, nothing we can see, then going through another biopsy just for a load of negative biopsies is tricky. Sorry, I can't. I'm not able to give you an awful lot of comfort.
Thank you very much for that, Anne. And I'm gonna, I think, you know, just say from everyone here, you know, I've had a lot of messages saying thank you very much for your answers. You know, gentlemen, really appreciating your sort of, you know, I know we sort of delved a little bit off topic, but you know, I thought it'd be a lovely opportunity for them to hear,
Sure.
from you.
Well, wish everybody luck.
Brilliant. Thank you again, and have a wonderful day, everyone. And I hope to see you next month for some of our sessions on the future of treatment. Take care. Thanks again, Anne. Bye-bye.